A very good evening. Am I audible?
Yes, sir.
Can we test the slide share if you permit?
Yes, sir. Yes, sir.
Is it visible?
Yes, sir.
And they are getting changed also?
Yes, sir. Also, sir.
Well, thank you. I'll just stop it. Thank you so much. Well, shall we start?
Yes, sir, you can.
Okay. So, good afternoon, everybody. And we are continuing with the series on clinical medicine. And this today's topic in the series of gastroenterology topics is interpretation of liver function tests. So, I will just start with my slides. Most of you may be well aware about the details of what I am going to talk about, but I am sure that it will be a good revision. And if you have some inputs, please share on the chat box. That will be good, and we can have some interaction at the end or maybe in between also. So, this is a very common thing. What actually do we mean with liver function tests? And when you are seeing patients, or many times patients will come with some or the other reports. So what exactly is meant with liver function test? So when we do liver function test, we do it as part of screening. So especially when we are going for a health checkup camp, or when we are going for a investigations of our patients who are coming. Because liver, as you understand, is the metabolic storehouse, and it is important, and it can be affected than any part or any disease spectrum. The other thing, when we talk of liver function test, when we order it, is as part of the pattern of disease. We want to understand whether it is an hepatic disease or an extra hepatic disease. By an extra hepatic disease, good morning, sir, Dr. Kamlesh, sir. Sorry, I just started. Okay, so sir is instructed to continue, so I will just continue. I will have his inputs at the end. So when we talk of extra hepatic, we try to identify the pattern of involvement of liver. That then also we order the liver function test. So it may be an extra hepatic disease where we actually talk of cholestatic disease. But yes, in the clinics we also talk of the pre-hepatic or the hemolytic part, wherein the liver may be involved, although not very significantly. I will come to that when I talk of bilirubin. But yes, that is also involvement in clinical medicine. The other thing, when you want to order LFT or when you think that LFT should be ordered or requested, is when you want to assess the severity or try to prognosticate the patient. So, the outcome of the disease. So, that is some things that I have just written: the synthetic dysfunction and the Madri's discriminant function, which when we talk of outcome, we all understand that a score which is more than 32 in alcoholic hepatitis indicates a poor prognosis. Now, this poor prognosis is a mortality of 30 to 50% at 1 month. So, that is the thing that we can all identify. If you have a patient who has alcoholic hepatitis, you calculate this discriminant function or the MDF, Madri's discriminant function, it is more than 32. You should understand it is a poor prognosis, and that poor prognosis translates to 30 to 50% mortality at 1 month, which is a very high mortality. So that is how you can actually prognosticate the patient, or you may be aware about the outcome also. So you can prepare accordingly, you can intervene accordingly, and that intervention in this group is corticosteroid treatment, where they can have some benefit. Uh, so how do you calculate this? I have just mentioned, although most of you must be aware. So 4.6 times the prothrombin time plus serum bilirubin. Now this is prothrombin time difference. So don't calculate the absolute value of prothrombin time. So the excess of prothrombin time as compared to the control. So if your control is 13 seconds, your prothrombin time is 23. So that means it is 10. The difference is 10. 23 minus 10. So 10 into 4.6 is 46. If the bilirubin is 2, 3, 4, 5, whatever, then the score is more than 32. So that indicates that the patient, 1 out of 2 or 1 out of 3 of such patients are unlikely to survive at 1 month. The last category I have mentioned is for follow-up. So many times you want to follow up the patient. That indicates where the patient is improving, deteriorating, and whether you have to intervene or not. So follow-up also recommendation is there. At times you just want to monitor fatty liver. You have some transaminitis, want to monitor the patient. So maybe after 3 months or 6 months, you will again get a liver function test. Now, when we talk of liver function test, it is important to understand that what is the liver function that we are assessing. So the liver functions that you are assessing, many times we include other tests also. I have also mentioned in my later slides what all will test for liver or indicate a disturbance in liver, but they are not actually liver function tests. In fact, this is a misnomer because you usually the liver has so many functions. You cannot have one test actually which can be labeled as a true liver function test. Many people have renamed liver function tests or LFTs as biochemical tests of the liver. So for different functions, you will have different tests. So I have tried to group it into different categories. So this is what it is. So tests for transport and drug metabolism, where you test for serum bilirubin, urine bilirubin, and urobilinogen, urine urobilinogen. So this will indicate the tests of transport and drug metabolism. So basically it is the heme component which is actually converted to bilirubin and then metabolized. So it is excreted into the biliary canaliculi, and you can test for transport of bilirubin as well as the metabolism. The other is test of biochemical activity, where actually we test for liver cell injury, where you have the transaminases characteristically, and then you have test for cholestasis, where you test for the bile salts, or at times alkaline phosphatase and GGT. So that is the biochemical activity that you test. Then you test for liver synthetic activity, which I mentioned just in the previous slide. So you have serum protein, serum albumin, basically specifically, and then again less common now. The upper three categories are commonly encountered. We get them tested every right, left, center. But at times you test for substances which are actually metabolized by the liver or cleared from the plasma by the liver, which is ammonia, because most of the drugs, most of the metabolites will be excreted or cleared from the plasma by the kidneys, but ammonia is cleared by the liver. So this is again very important. If you have high ammonia levels, that is one of the discriminating factor in a patient of encephalopathy, whether it is renal or it is hepatic. So if the serum ammonia levels are elevated, it is probably hepatic encephalopathy and not uremic encephalopathy. So this test also at times when you are in doubt of the etiology, you do get it done. Although very late in the disease, there will be hepatorenal syndrome or renohepatic syndrome where both the organs will be involved. So you may not be able to discern the primary organ. But yes, in hepatic encephalopathy patients, if your serum ammonia is high, then probably it is hepatic encephalopathy. On the contrary, in hepatic encephalopathy, if the serum ammonia levels are normal, then probably you should rule out other causes of encephalopathy. This is important. So just some things. A specific investigation of liver disease. This is not classical liver function test, but again I have mentioned them, or I have, for completion's sake, I have also mentioned the imaging studies, histological studies. That is why I told you liver function tests are actually a misnomer, because there is no one test which will actually test like thyroid function test, where you have the TSH, T3, T4, where they will give you most of the liver, the thyroid functions. But liver functions, for each metabolic component or each function of the liver, you will have a different test or a group of tests. So with that, I will move further. So now this is the first, bilirubin. I talked of bilirubin here. So test of transport, drug metabolism. Bilirubin is important. Now when you talk of bilirubin, you have, I think I just missed this slide, but anyhow, I had showed that slide in my first lecture, that if you have bilirubin which is increased, then most of the time it is conjugated hyperbilirubinemia. If you have unconjugated hyperbilirubinemia, the causes are mentioned here, but that means that there is some hemolysis which is there, which could be intravascular, extravascular, which could be because of RBC membrane defects, which could be because of hemolytic anemias. So this, in fact, at times it could be because of increased turnover also. So this is important that you should understand unconjugated hyperbilirubinemia. Now, this is most of the times if you do not suspect, especially if it is a chronic hemolytic anemia, then where you have a very slight lemon yellow tint which can be easily missed if you do not see in broad daylight. This will be picked up as an abnormality on routine testing of the liver functions. So in those cases, you have hyperbilirubinemia, and importantly, liver has a very tremendous capacity to conjugate. That is why it is not a, even if the liver is normal and this hyperbilirubinemia is occurring, it goes to the liver, it gets conjugated and then it gets excreted. So there is no conjugated hyperbilirubinemia in unconjugated or hemolytic cases. So you will have an indirect indirect bilirubin which will be high, which may be of the order of more than 60, 70%, 80%, 90% of the total component. In that case, you say that it is an unconjugated hyperbilirubinemia. And mind you, conjugated hyperbilirubinemia does not accompany unconjugated hyperbilirubinemia in cases where purely the lesion is hemolysis. I think I have a case where you should, if you have both components, you say conjugated hyperbilirubinemia if it is more than 50%. So those both the things will not occur together. There may be some hemolysis in chronic liver disease wherein you will have conjugated hyperbilirubinemia and small amount of unconjugated hyperbilirubinemia. But then you say conjugated hyperbilirubinemia when it is more than 50% of the total bilirubin. So in no case there will be a unconjugated, because their definition is more than 70, 80, 90% of the total bilirubin. So you should understand there will be some components, because the disease, it may be a sepsis or it may be a chronic liver disease with some hemolysis component. But you should be very clear whether it is an unconjugated hyperbilirubinemia or it is a conjugated hyperbilirubinemia. I have a couple of cases, we will discuss this later. And the causes are primarily hemorrhage or hemolysis basically. At times in hemorrhage also, because there is a collection which has to be metabolized. So you will have internal hemorrhage even in polycythemia. So whenever there is some amount of increased RBCs or metabolism of RBCs, you will have some amount of unconjugated hyperbilirubinemia. So that is what. Now the last line is important. Crickler-Najar obviously you do not see in adults, but Gilbert's very commonly as part of routine health checkup. In fact, when we also get LFTs done, you will find there is a serum bilirubin which is 2.5 or 2.2 milligram per deciliter, and the unconjugated fraction in that is 1.6 or 1.7 milligram per deciliter. And in that case, LFT, SGOT, SGPT may be near normal, just slightly elevated, and you get worried about it. That what will happen? I am not, you don't manifest jaundice, but at times you have some malaise, you feel that the patient, we are not having mm, good appetite. So these kinds of patients will come. Now this you should understand, this is one of the commonest abnormalities which are there in the general population, which is Gilbert syndrome, which is a congenital unconjugated hyperbilirubinemia. So in adults, it will manifest. You will have these patients in commonly in public also. And in case you get an LFT done, you will find an unconjugated bilirubin, which is constituting a major component of the total bilirubin. And SGOT, SGPT may be normal or slightly elevated. And mind you, these patients will remain asymptomatic most of the time. But at times, what will happen? They will catch a viral infection or any infection. And at that time, because the liver will be in stress, they will have slight elevation of bilirubin, unconjugated. And you will also have slight elevation of transaminases. And then they will get their investigation done. And once you get their investigation done, you pick up that they are Gilbert syndrome. So always remember, because in hemolysis, chronic hemolytic anemia, you will have a higher bilirubin, which is much higher, and jaundice also would be apparent. Lemon yellow tint of icterus is usually apparent in hemolytic jaundice. But in Gilbert's, you at times, when they have this decompensation or an intercurrent infection, not decompensation, but intercurrent infection, in those patients, you will have some lemon yellow tint, and it is a self-limiting illness. Very rarely in patients who may be symptomatic and it is persisting, you may need to give some enzyme inducers, but otherwise it is a very benign condition and it will continue lifelong without any adverse component. So this is important because you should identify a serious illness. Now, how will you differentiate whether it is hemolytic anemia, which is causing unconjugated hyperbilirubinemia, or Gilbert syndrome, which is resulting in mild unconjugated hyperbilirubinemia? Supposing chronic hemolysis is occurring and your serum bilirubin is also 1.2. What will be the first thing that you will order or like to see? Clinically, hemolytic anemia will have splenomegaly. Gilbert's will not have splenomegaly. Gilbert's, you can get a history of recurrent. Yes, hemolytic disease also you can get, hemolytic anemia also you can get history of recurrent episodes, precipitating episodes. But if you get a retic count done, retic count will be high in hemolytic anemia, unlike in Gilbert syndrome. So this is important for all of you to understand apart from other factors, but yes, this is okay. Now coming to conjugated hyperbilirubinemia. So this is when you say that direct bilirubin is more than 50% of the total bilirubin. So this is the most common entity that you see in inpatients. So you have a whole lot of infections, you whole have toxic injuries where it could be drug induced, alcohol induced, and at times occupational disease also, ischemic causes, and autoimmune liver diseases. Now the upper three are usually seen in pediatric population. We usually do not see, but yes, with therapies and with mild variants, you can have these diseases in the adults also, and especially metabolic liver diseases. Now you are having a lot of them in the adults also. So this is important. This is common that we see, but and I think most of you know these things. We will just go in a little more detail later. When we talk of bilirubin, the next thing that we get when we order serum bilirubin, total, direct. So direct and indirect. Indirect is hemolytic or unconjugated hyperbilirubinemia, and direct is hepatic, primarily with conjugated hyperbilirubinemia. The other is now aminotransferases. So you have two, we all understand aspartate aminotransferase, AST and ALT. And ALT is from the liver, alanine transferase, and AST is primarily, it is also from the liver, but there are secondary sources like the heart, which is important. And I think I have mentioned about the ratio, but yes, so we can classify them as mild elevation, moderate elevation, and a very high elevation or a severe elevation. So if it is 1 to 3 times, so different labs will have different cutoffs. We usually take a cutoff of less than 40 unit per liter. So that is what, at times you can take it as less than 45 also. But remember, when we talk of these biochemical values, more than 1.5 times upper limit of normal is considered as abnormal with all variations. So if you take as 40 as the upper limit of normal, more than 1.5 times means 60. So any patient who has more than 60, definitely it is abnormal. So it may be clinically relevant at that point of time. Mild elevations you can still see in these conditions. But important for adults is drug-induced injuries, even mild infections, infections like influenza, which have some viremia component and a multi-system involvement. But now this NASH or MASLD, metabolic dysfunction associated steatoliver disease. Now this is one of the commonest in practice. So in your OPD practice, this is the commonest entity which will contribute to mild elevation of transaminases. So you will have some 50, 60, 65 AST or ALT, and your patient who is slightly obese or is having central obesity. That is the typical presentation that you have in most of these patients. So you can order an ultrasound and then go ahead and work him up for a fatty liver or MASLD with transaminases. And you can monitor also, as we said, 3 monthly or 6 monthly, you can get it done. The second category is moderate elevation. Now, this is also very commonly seen, but these patients usually you have to admit or you have to work up and then you have to see whether you can discharge them if the AST, are stabilized. So viral hepatitis, very common. Summers are coming. We will have a greater incidence of these patients. Parasitic hepatitis, especially amoebic liver abscess, and even typhlitis that is there. Chronic hepatitis B and C, Wilson's disease, and cholestatic liver disease. So in cholestatic liver disease also, because of regurgitation, at times you will have some component of transaminitis. So there will be some overlap with transaminitis and with obstructive liver disease or cholestatic liver disease. So that you have to understand. Even with acute hepatitis or chronic active hepatitis, where you have a chronically deranged liver and transaminitis is there, because if the hepatitis is active, there is swelling of the hepatocytes. So they will obstruct the canaliculi. So you do have some component of cholestasis even in acute viral hepatitis, especially if it is severe or if the injury to the hepatocytes is uh, a little more. So that is important. Similarly, likewise in cholestatic liver disease, you will have some component of transaminitis also. Now, marked elevation, this is very important. So, if you have marked elevation, which is of the order of 600, 700, then you should think of toxic hepatitis and ischemic hepatitis. These two are the most common conditions where you should think. At times, fulminant hepatitis. So, acute viral hepatitis leading to fulminant hepatitis will also lead to a marked elevation of transaminases and acute Budd-Chiari syndrome. So these are some classical conditions where you will have, sorry, I have mentioned ischemic hepatitis twice, but yes, these are some classical conditions where your ALT, AST may be maybe at times in thousands. So you should think of ischemic hepatitis, you should think of fulminant hepatitis, you should think of toxic hepatitis. This DILD is drug-induced liver disease. So toxic hepatitis includes drugs, it includes toxins, it includes your alcohol, which is also a toxic, or at times people include it as drug also alcohol. But anyhow, whatever it is a toxic hepatitis. So these are some of the conditions you should think of whenever you have an abnormality. Some important points when you are talking of transaminitis or elevated aminotransferases, you should always think if your patient has a elevated aminotransferases and suddenly it goes up. Okay, we will talk of sudden or rapid decline. If it goes rapidly, it declines, then it is a basically fulminant hepatitis. That means the all your hepatocytes. So what will happen in early stage when hepatocyte necrosis is there? Then all these aminotransferases will be released. So you will have a very severe surge. So and after that, once all your hepatocytes are gone, you will have a fulminant downgrade of the all aminotransferases. So if the rapid decline is there, it is a very bad sign. That means all hepatocytes are actually necrosing. So if they necrose, then obviously you understand that the only possibility for which will remain is regeneration. And in fact, these are the patients who actually require liver transplant. So this is a very bad sign if there is a rapid decline. The second is serum bilirubin level gradually rises and then transferases. So this is important. Many times you will see in your wards or your clinical practice, you will have transaminitis and bilirubin is 3. Liver enzymes are 200, 250. And you make a diagnosis of acute viral hepatitis. You put the patient conservative. Now, when you repeat it after 3 to 4 days or 5 days, you find the liver transaminases are the same, but bilirubin has increased. And you start panicking. That patient is deteriorating. Now we should all understand that transaminases or transferases will increase first and bilirubin lags a little. So serum bilirubin level gradually rises compared to transferases in acute viral hepatitis. And similarly in recovery phase, transaminases or transferases will revert back earlier, indicating recovery, and bilirubin may lag behind. So this is important. Rather than panicking, we need to be more aware about such patients. I think I have mentioned, yes, serum transferases may show steady decline before serum bilirubin in uncomplicated hepatitis. Now, if there is a secondary elevation, it indicates that secondary elevation means on a elevation, then it suggests that there is a chronic hepatitis, underlying chronic hepatitis leading to, and then there has been a resurgence, what earlier was known as a chronic active hepatitis. Now, this is very commonly seen in our wards in clinical practice, an AST-ALT ratio reversal. Usually in liver disease, you have ALT, which is higher than AST, which I was talking about. But if on the contrary, if it is reversed, then you should think of alcohol as an etiology and at times infiltrative disorders like Wilson's disease. So this is important for all of us to remember. Coming to now, we have talked of bilirubin, we have talked of STLT. So I will be a little quick because now we have already completed nearly 25 minutes. I don't want you to hold for very long. But yes, test for cholecystitis. The second component is the domain which we usually think that it is surgeon's domain. But it is equally important for us to understand what actually contributes. And many of the diseases are medical only. So you have two tests, alkaline phosphatase and gamma glutamyl transferase. Now you should understand that these tests we know little. We know much about STLT, we know about bilirubin, and we once they are in medicine, we try to think less of ALP GGT. But it is important that we deal with ALP also, which is very important because it is not only liver but other diseases also. So sources of liver is sources of alkaline phosphatase, liver, bone, intestine, kidney, and placenta. Now, range could be anywhere from 45 to 115, I have written, but yes, there are different assays, and in fact, it can go up to 250 or 300 also, which may be a normal range. In fact, when I was a student, it was calculated in Ka units. So, depending upon different assays, you should consider 250 or 300 up to 300 a normal range for alkaline phosphatase. Now, alkaline phosphatase as well as GGT in our clinical practice, we consider them as cholestatic markers or biliary damage markers because they are secreted from the epithelium of the biliary tract. So, yes, the causes we have mentioned cholestatic jaundice, infiltrated disease of the liver like malignancies. So, this could be primary malignancies which are causing obstruction, or it could be a metastatic infiltration of the liver. Acute viral hepatitis, I already said, with swelling of hepatocytes, the cannulae get blocked, and yes, you will have some amount of uh, cholestatic component. So you will have some elevation of alkaline phosphatase. So it could be normal or moderately increased in acute viral hepatitis, and similarly in cirrhosis, because cirrhosis also you have regenerating nodules. So the all architecture of the liver is distorted. Now in vitamin D deficiency, it is not the liver source, but it is the both source. So vitamin D deficiency, osteomalacia, very important, will lead to alkaline phosphatase, which is high. Graft rejection at times will result in alkaline phosphatase, which is high, and use of drugs like antibiotics. Some of the drugs would cause an alkaline phosphatase, which is high, especially antibiotics, tricyclic antidepressants, and ACE inhibitors. The newer antibiotics are more prone. Now, there are some conditions where you will have a low ALP. You should know about this also. So, one is Wilson's disease. So, you have alkaline phosphatase to bilirubin ratio less than 4 and congenital hypophosphatemia, at times and hypothyroidism and pernicious anemia. So these are some conditions where you will have a low alkaline phosphatase. GGT, now GGT up to for 30, 45 is considered normal. Higher than that is high. So all biliary tract abnormalities and especially primary or secondary sclerosing cholangitis. Drugs like phenobarbital, phenytoin, paracetamol, tricyclic antidepressants, and at times obesity, pancreatitis, GBS, they will also be associated. Some conditions will have low GGT. This is important. Now, I have not mentioned this familial intrahepatic cholestasis 1, 2, 4. In 3, the GGT is high. So, now these are very remote, or we don't usually encounter these conditions, but yes, you should have at the back of mind benign recurrent intrahepatic cholestasis, arthralgia, renal abnormality cholestasis syndrome. These are some conditions where you will have a low GGT, and low means when the range is 0 to 30, you should think that it is between 0 to 5. So these, for completion sake, I am telling you this, you should be aware. Now, the third category is tests of synthetic dysfunction. So we have serum albumin here and prothrombin time. Now this again component you know better because you are dealing with these patients every day. Serum albumin, the normal range is 3 to 5 or 3.5 to 5, 2 to 3.5. Basically, this is normal ranges of 6 to 8. Yes, okay, 3 to 5 or 3 to 5.5 or 3.5 to 5.5 is normal range of serum albumin. Total proteins is 6 to 8. grams per deciliter. The half-life is 20 days. Now, this is important. This is for endogenous albumin, which is synthesized by the body. What is given as albumin infusion, the half-life is only a few minutes to hours. So, this is not of half-life of the exogenous albumin, which is infused. So, low serum albumin is a sign of a chronic liver disease and chronic disease. So, chronic malnutrition will also result in low serum albumin. But importantly, decompensated liver disease, you will have an abrupt decrease in levels following an acute illness. So, any decompensation, you can have rapid decline. So, at times, even in viral illness, you can have, especially I was talking about influenza. So, if the patient is decompensating, or the patient is having toxic injury, so you can have a rapid decline in serum albumin. Otherwise, usually, if it is a well-built patient and it is a chronic disease, you will have low serum albumin. But very rarely, even in enteric hepatitis at times, you will have a very rapid decline because these patients are very toxic. So you will have albumin levels which will the go down from the pre morbid state very rapidly. So it depends upon the illness. Although usually we take it that low serum albumin is synonymous with a chronic disease. So in liver disease, you should check that if the patient is having a history of about 6 weeks, 7 weeks, and the serum albumin is low, then probably the patient is having a chronic underlying liver disease. And chronic disease, I also said, like tuberculosis and malignancies, where also you can have a low serum albumin. The second component, now these are all synthetic dysfunction. Synthetic dysfunction means synthesis by the liver. So that is dysfunctional. So albumin is one important feature. Prothrombin time is the second. These are two which we actually monitor. So normal range is 11 to 14 seconds. Now this is important, although we are in the realm of INR or international normalized ratio, but any abnormality or derangement from the control value, which is more than 3 seconds, up to 3 seconds is normal. So if the control value that is given by the laboratory is 13 seconds, if mine is 16 seconds, I am normal, because 16 minus 13 is 3 seconds, up to 3 seconds is normal. If the control value is 11 and mine is 16 seconds, the difference becomes 5 seconds. This is abnormal. So this is important for all of us to understand. Don't take absolute value, always compare with control. So that is what will indicate that there is a prothrombin time which is abnormal and which could be a manifestation of abnormal coagulation or vitamin K deficiency. If not, then your patient is sick. It could be a manifestation of chronic liver disease, acute liver failure, or acute or chronic liver failure. This is very, very important because then you will need to take care of these patients on a critical basis. Now, this I already talked about. So, you can test for substances cleared from the plasma by liver. The plasma ammonia is what we commonly use, but yes, in inborn errors of metabolism, you can also test for amino acids, specifically for tyrosine, phenylalanine, and methionine. And I already mentioned plasma ammonia levels would be elevated in acute or chronic liver failure and will correlate with encephalopathy status also at times. Globulins, now globulins, autoimmune hepatitis, you can have raised elevation, especially in chronic liver disease. You can have IgG elevations or you can have IgM elevations in primary biliary cirrhosis. Bile acids, bile salts. Now these are elevated in obstructive jaundice. So because there is an obstruction somewhere in the biliary tract, the bile acids will get elevated. And these bile acids will actually be then secreted or excreted by the kidneys through urine. So that is what you can test and that will indicate cholestasis if there are urine bile salts which are positive. Because usually they are passed by the intrahepatic circulation and released back into the gut. And if there is no obstruction, you will find bile salts which will not appear usually in urine. Low levels could be there in bile acid synthetic defect, and this actually differentiates from progressive familial intrahepatic cholestasis compared to bile acid synthetic defect, wherein you have bile salts which will be low. Now, this I just talked about. You have additional investigation. So, we completed with liver function test, but at times you will suspect liver disease and you will need to do much more. So wherein you may need to do a septic screen, you will need to do viral markers to find out the etiology, the mass spectrophotometry for metabolic screening, the inborn errors of metabolism, alpha fetoprotein for malignancies, serum ceruloplasmin and urine copper for Wilson's disease, non-organ specific antibody again for autoimmune components, so anti-nuclear antibodies, SMA, smooth muscle antibodies, and LKM, liver kidney muscle antibodies. All these you need to do. Thyroid function test, yes, important, because hypothyroidism as well as hyperthyroidism both can have hepatitis plus the with hypothyroidism or hyperthyroidism, because the BMR and the activity of enzymes is also altered. So the liver is directly related to it, because you will have a slow metabolism. So the metabolism organ is liver. That is what thyroid function tests are very important. Hypothyroidism as well as hyperthyroidism both affect directly the liver. Urine non-glucose reducing substances, again, inborn errors of metabolism. So you can have galactosemias, fructose intolerance, where these could be positive. Tyrosine urine succinyl acetone, that you get it done. Usually in children, we don't get it done in adults, but yes, you should be aware about these. And in cystic fibrosis, fat chloride test, that is requested. Some other investigations, radio imaging, we will have a couple of cases, so we will discuss that. At times, you will need to get a bone marrow done. So, which is important, especially if you have lymphomatous infiltration, liver biopsy to understand the liver architecture, endoscopy to confirm for varices, and cholangiography for especially obstructive defects. Now, this is a scenario. I have three scenarios, and I think we will finish within 5 minutes now. Three scenarios. This 50-year-old male consumes alcohol regularly for last 25 years, 3 to 4 quarters whiskey daily. The bilirubin is 35 milligram per deciliter total. Direct is 28. So indirect is 7 milligram per deciliter. So what is this? This is in conjugated or unconjugated? Do we have the chat here? Just a second. Anyhow, oh, my marker is on probably. So you have this is basically conjugated hyperbilirimia, because you have the direct, which is 28, which is more than 50% of 35. The AST, ALT are mildly elevated. ALP is within normal. As I said, you can take up to 250, 290, 300 up to normal. GGT again is mildly elevated. And serum albumin is low, 2.2 gram per deciliter. Prothrombin time is 30 seconds. Control is 13 seconds. So somebody else is using the marker, not myself. Anyhow, so what do you think this is? So, yes, chat box says yes, I get it now. So conjugated, yes, you are right. And we have now, see, the AST, ALT are mildly elevated. So in this patient, it is important that mildly elevated, as I said, it could be just metabolic dysfunction associated liver disease. You will need to investigate. But since there is a definite history of alcohol, you should think, yes, very right, it could be an acute or chronic liver disease. The AST, ALT is more than 2, very right. So alcohol has its effects. That is why AST, ALT is reverse. The ratio is reverse. You should have in liver disease ALT which is high. The bilirubin is very high. That indicates that the patient is having a liver disease. There is a dysfunction. Metabolism is different. The prothrombin time and the albumin, both the synthetic dysfunctions are gone. So you see liver as a composite organ. You see that the transaminases are mildly elevated, but bilirubin is high and the synthetic dysfunction is also lost. It is also hampered. Now remember, over a period of time, what will happen when there are no hepatocytes, as I said, to get destroyed or get injured to release AST-ALT. So your AST-ALT will not rise so much. So this probably indicates that the patient is gone down for a very long time. And it is already mentioned here, it is a case of decompensated chronic liver disease and has again taken an alcohol 3 days back. So probably that is why he has acutely deteriorated and presented to you as in an emergency. So I think most of you get it. We will move to the next case. So this is the asymptomatic male, 40-year, investigation reports on routine health checkup. The bilirubin is normal, direct is 0.2, indirect is 0.7. Anyhow, AST is 120 units per liter, ALT is 75 units per liter. And alkaline phosphate is normal, GGT is normal. So AST and ALT are elevated. And albumin is on the lower side or maybe normal 3 to 5.5 if you take, it is normal. Prothrombin time is normal, 2-second difference. So this is an asymptomatic male who has transaminitis. So now you will need to investigate. As I said, yes, if the patient is obese, it may be part and parcel of MASLD or fatty liver. So you can get an ultrasound. But yes, still if it is MASLD, you should investigate the patient for viral hepatitis. So hepatitis B, C have to be ruled out. You should get it investigated and you need to see. But again, in this case, AST, LT are more or less the same. The ratio is not reversed, although AST is slightly higher. So you should take history of alcohol also in this patient, and you will need to work up this patient. Don't leave this patient. It is important because you will need to catch the disease early, liver disease. This is the third case. This is a 55-year-old male with hepatitis C. He had contracted HCV when through a brief period of IV drug use over 30 years ago. Now, this patient, the physical examination is unremarkable for presence of chronic liver disease, so we do not have any stigma of liver disease. AST is 78, so this is elevated, nearly twice the normal, upper limit of normal. AST is again the same. Albumin is 3.4 gram per deciliter, so lower side, but yes, within normal range. Platelets are slightly again on the lower side, and INR is 1.3. So, what do you think this patient is having? What should we do for this patient? An abdominal ultrasound indicates a diffusely fatty liver measuring 13 centimeter. Now, this patient has chronic liver disease probably because hepatitis C infection was there. It is not mentioned whether it was treated or not. So, yes, you are correct. This is a chronic viral hepatitis, probably related to hepatitis C. And you have a fatty liver enzymes are normal, but don't leave this patient because everything is normal or near normal. You need to investigate that this patient, and especially in this patient where you know that hepatitis C will need to be ruled out and can result in as chronic viral hepatitis or a chronic hepatitis state. What you need to do is you need to assess for either get a biopsy because the liver enzymes are elevated, or you get a fibroscan in this patient. In fact, a fibroscan was ordered in this patient, and at 12 valid readings were obtained from the right lobe of the liver with a median liver stiffness of 26 kilopascals. So you have, this is basically vibration control transient elastography, and you have normal values which are less than 7. In any normal adult, you will have liver which will be not having stiff, so it has to be less than 7 kilopascals. If it is high, then definitely there is some component of fibrosis, and any reading of on fibroscan or VCTE, vibration control transient elastography, if it is more than 14, then definitely there is a very significant element of fibrosis. So this is important. So you will need to either biopsy the liver in such patients and check for the fibrosis component, because you need to actually find out and give the prognosis to the patient. It is very important. So this has a median liver stiffness of 26, which is very, very high. And probably this patient is chronic liver disease, although the physical examination is unremarkable. So even slight elevations, you should always check and give the patient a complete diagnosis and don't leave the patient uninvestigated or just like that. So this is important, although the patient appears although very similar. And yes, there is a suggestion that other etiologies should also be considered. So yes, well and good, there could be co-infection. In fact, you can have HCV, HIV co-infection also. So everything has to be done. You should not take that, yes, one day diagnosis you have, you should forget about others. And the reading about this 12 validating this, that it is important that many times people screen use this. There are camps organized by many NGOs also, some pharmaceuticals also, at times institutes also. They organize camps of fibroscan. But in those scans, they usually put the probe in one area, and in a hurry, you will miss because it sees only one cross section through the liver. So if you have the greater the number of readings on a single patient in a single setting, the higher will be the success rates of catching fibrosis and having the true representation of the fibrosis component. Otherwise, you can have because fibrosis and regeneration in cirrhosis is not uniform. Maybe left lobe, right lobe, posterior lobe, superior lobe. Anything could be more involved than the generalized. In a very advanced state, yes, it can be generalized. But nodular regeneration will occur inhomogeneously. So it has to be important that you should have complete data set when you are actually giving the prognosis to the patient. I think that is what it is. Yes, thank you so much. So if there are any queries, I will be glad to answer. You can put it on the chat and I can try to answer. So there was one query, probably I will just see. Will ammonia levels be always raised in encephalopathy? Yes, ammonia levels would be elevated in encephalopathy. But yes, if the patient goes into a chronic hepatic encephalopathy, then the ammonia levels will come down and the patient would be much better. So even the patient will have some elevation of ammonia levels. You may find the patient is completely normal because he is in a chronic encephalopathy state. So that is important. It is not always that you will have patients who have ammonia levels which are high and they are always incoherent and vice versa also. So in patients with elevated liver enzymes, how effective are LFTs at differentiating hepatic and extrahepatic causes of enzyme elevation? So in cholestatic component, if you have categorically, if you have ALP and GGT elevated or only ALP elevated and SGOT, SGPT near normal, then definitely it is an extrahepatic cause. There is no doubt about it and vice versa. At times the problem is, as I showed in the cases, there is mild elevation of ALT, AST, there is a slightly greater elevation of ALP, where then your clinical acumen and history at examination and past history at times plays a greater role. Patient with CLD previously now recovered, but bilirubin is persistently in range of 1.5 with enzymes at upper limit of normal. Next step, wait and watch or something to be done. See, if the patient is chronic liver disease, there is nothing like wait and watch. You have to put the patient on CLD management, the etiology, as well as the components that the patient is having of chronic liver disease, be it varices, be it electrolyte imbalance, be it SBP, those things will continue. And we don't want that. Bilirubin should normalize. Bilirubin values do not make much of a difference. So you should not worry about bilirubin. So if it has come down to 1.5, well and good. Don't worry about that. You are more bothered about enzymes. Every time the enzymes get elevated, that means there has been an injury to the hepatocytes, which in chronic liver disease anyway are down because you have to salvage those hepatocytes. So you have to prevent that rather than bilirubin. Don't worry about too much about bilirubin. Bilirubin asymptomatic rise is common with drugs, especially there are so many drugs which can cause, and it will not create a lot of problem for you, for your patient, I mean. So obviously for you also. To what extent can LFT abnormalities predict the progression of NAFLD to NASH in asymptomatic patients? Now, this is a very difficult scenario because if your LFT is deranged, there are no studies per se right now because you need cohort studies, you need to follow up the patients from NAFLD to NASH or MASLD to MASH, asymptomatic patients. And this is a new disease or new terminology which has occurred in last few years. And what is fatty liver is ultrasound dependent. So we do not know how far it is actually a fatty liver. But definitely grade 2, grade 3 is what we are concerned about. If you have grade 2 or grade 3 fatty liver on ultrasound and you have transaminitis, then definitely you should advise the patient for weight reduction if the patient is obese. You should advise the patient to control all the other metabolic parameters and also monitor the transaminases, which should come down with weight reduction and control of lipids, diabetes, hypertension, and a good lifestyle. Otherwise, prediction is not possible right now. We don't have tools for prediction. But transaminitis persistent is not a good sign. Acute liver injury in sepsis or poisoning. What are the liver supportive measures to be taken? So, see, liver has a tremendous capacity to regenerate. So, you don't have to worry much about the liver in acute injuries unless until I showed you that your patient is going down. So, if the patient has decompensation in acute liver injury, that is a big problem. But if the patient is recovering, that means the gradually your SGOT, SGPT or AST, LT are recovering, then it is a very good sign. But yes, as I said, rapid decline is going to be a problem. That means the hepatocyte reserve is just going down. So that is what you have to take care of. And liver supportive measures are dietary. Yes, you should give a very light diet to the patient. Ensure the patient does not get into hypoglycemia. And you should actually monitor blood sugars and the caloric intake. Ensure that the patient does not have catch intercurrent infections because liver also controls the immunity. And other pharmaceutical agents which are advocated for use as liver supportive measures, they are of dubious benefit. I cannot overboard recommend them for use because the evidence today is lacking on those. Novel biomarkers derived from LFT or early detection of liver fibrosis and cirrhosis. So there are a whole lot of tools. People are devising indices, which I would say that the CTP grading, the child Charcot Pukes gray staging, that is very important if you have to think about the outcomes and the MELD score, so which have been already discussed earlier. So I think those are the things which you should tool because which you should assess in each liver disease patient and in chronic liver disease, and that will actually help you out. The novel biomarkers are only of research interest and not in to be used in clinical practice as of now. How systemic disease and diabetes or hypertension affect LFT results? So they do not affect LFT results unless until there is fatty infiltration or what we label as MASLD. The secondary is that they affect the drugs that you use. Drug induced injury can be there. So especially in diabetes, you have to be very careful if the patient is having liver disease and vice versa. So liver disease patients more prone to develop diabetes. For diabetes, the drugs that you give, you have to be very careful with liver functioning. Is it possible to say based on the bilirubin levels if it is just DCLD or an acute or chronic liver failure? That is, can bilirubin levels go beyond 5 to 10 milligram per deciliter in DCLD? Well, it will all depend upon what stage of liver disease the patient is having. If the patient has already very late decompensated chronic liver disease, the bilirubin may not rise so much. But yes, early in the stage, you can have all components. So it will all depend upon the stage of liver disease. That is what I believe. Role of FFPs in management with melena, patient with melena, but hemodynamically stable. No, if the patient is bleeding, now this patient is melena. Melena can persist even for 2 to 2.5 times days later than the patient when the patient has bled. So hemodynamically stable is okay, but if the INR is deranged, you should actually transfuse the patient. If you think that the patient has recently bled, because you don't want the patient to bleed again. Because again the patient can start bleeding and you will never be able to, then it may be too late. So that there are, although there are some queries about doubts about whether it should give prophylactically or not, but don't, this is not prophylactic, this is recent bleed. So then you should give. Do we give albumin to patients with hypovolemia even if we are not doing a cyclic tap? Not at all. Albumin is not recommended for patients with hypovolemia. I told you if you give exogenous albumin or albumin infusion, it is metabolized to amino acids and amino acids that go to the liver and liver starts constructing albumin. And once it constructs albumin or synthesizes albumin, sorry, not constructs, synthesizes albumin, then your patients will have rise in albumin. So giving albumin is only a transient process. Don't give albumin in the hope that your patients will have rise in serum albumin. You give albumin, you give globulin, you give protein, you give amino acids. Everything will be assimilated by the liver, and then only serum proteins or serum albumin will rise. So whatever albumin you give, that is a transient way. That is that is basically to build up the colloid oncotic pressure. Because when you are doing an ascitic tap, you don't want that the patient should go into hepatorenal syndrome. So during ascitic tap, you give albumin or normal saline to keep the patient euvolemic, and in hepatorenal syndrome, you give albumin. Well, I don't see any more questions. So with that, I think if you permit, we can close down the session. It is an hour also.
Yes, sir.
Well, thank you. Thank you everybody for joining, and thank you so much. Look forward to having you all next week, and I will share the schedule shortly.